Buddy, this is Matthias Friedrich. Welcome to today's CMR Journal Club. It was a tight call today because I'm actually currently looking at the waters of Venice here at the meeting venue of Euro CMR. And until a few minutes ago, I was on a boat and it was almost too close. So Liz from my team in Montreal was already ready to jump in, but I'm happy to welcome you. So I don't know whether Borja Ibanez is already online, but so far I haven't seen him. He's maybe calling in. So we'll. Hello, who was that?
This is Borja joining.
Hey, Borja, that's great that you're here.
How are you?
I'm good. So again, welcome everybody, and of course a special welcome to Borja Ibanez. The senior author of the paper we discussed today. It's called Serial Magnetic Resonance Imaging to Identify Early Stages of Anthracycline-Induced Cardiotoxicity, published very recently in the Journal of the American College of Cardiology. And Borja's group is known to actually perform outstanding research, especially with an interest in edema imaging. And they have tackled a very important topic, namely anthracycline-induced cardiotoxicity. We know that clinically it's a huge problem. We discussed it that at one of the recent Journal Club meetings. And in a nutshell, a lot of the let's say cardiotoxic, but it's in fact an oncologic treatment. A lot of that treatment is cardiotoxic, so that in fact a woman suffering from breast cancer now is more threatened by dying from heart failure eventually than from breast cancer itself, and just because the medication is so toxic. And so far we do not have great tools to actually identify cardiotoxicity early enough so that we could either modify the dose or stop the treatment altogether or continue with a potentially life-saving treatment. So that's why this paper is so important, and the group chose to do what they're especially good at, use a very sophisticated animal model. So I'm very happy to welcome and thank already Borja for presenting their paper. So I will stop sharing my screen, Borja, that will allow you to share yours. I don't know whether you're familiar with Zoom. That is on the bottom of the Zoom window. Sometimes there are two Zoom windows and there's a share button. Yeah, and then okay, great. So I hand it over to you, Borja. Thanks for coming.
For the invitation, it's really a pleasure to be here with you today. So I subscribe everything what you have said as background. So our main interest was to be able to develop a translational model, and we have been working in pigs because it's very close to human pathophysiology. And this is why we wanted to have a pig model of anthracycline-induced cardiac toxicity. So as you have read, in this case, we are inducing cardiac toxicity in these pigs by injecting intracoronary doxorubicin. We're injecting 5 biweekly doses of anthracycline. This results in a clear left ventricular dysfunction, as I will show you later on. So maybe just as a side note, we have tried in the past to give intravenously doxorubicin in these animals, but we have not been able to induce cardiotoxicity, mainly because these animals, they have a huge myelosuppression and they die because of myelosuppression before they even have some sort of cardiotoxicity. Now we have other ongoing studies in which we are able to, by having 2 different stresses, to induce cardiotoxicity also by intravenous injection, but it's not in this paper. So as I mentioned, first we did a group in which we were administering this cardiotoxic anthracycline intracoronary. Let me go to this figure 2, and then we will come back to figure 1. So, and mainly what we were doing was to do a multiparametric MR serial study. So every week these animals underwent cardiac magnetic resonance, and we're doing T1 mapping, also native T2, and also we were doing post-contrast T1 mapping to be able to quantify extracellular volume. And of course we were quantifying CNA to check when these animals, they have a cardiotoxicity. So here in the bottom of the slide, you see the timing in which we were administering doxorubicin. So at baseline, this is the first dose. So every 2 weeks, we're giving a doxorubicin injection. And you can see this is the blue line, how left ventricular ejection fraction in these animals starts to decline between the 4th and 5th dose. So it was completely normal, the first 4 doxorubicin injections, which was reassuring for us, because if we were start to have some dysfunction after the first injection, most probably this could have been done secondary to the route of administration. And you can see how this ejection fraction goes really low. And at the end of the protocol at 16 weeks, they have around 25% ejection fraction. Also, you see in extracellular volume, so pre and post T1 mapping, you see that there is a increase in extracellular volume, which is more or less in parallel or inversely, but at the same time as the decline in left ventricular ejection fraction, and then this goes up to the end of the protocol. And what it was more interesting was to see that T1 mapping start to prolong or have significant prolongation much earlier in the course of the disease. So in these animals, we observed that T2 was prolonged after the third dose of doxorubicin. So it was clear that this was the earliest sign of some effect of the doxorubicin in the heart in these animals. So at this point, we wanted to check 2 different things. One, we wanted to see which were the pathology correlates of these changes, because this is extremely important to see what is the pathophysiology underlying these changes, and also a cardiotoxicity. And this is why we were doing tissue sample collection at these different time points. Sorry that I'm going too quick. And what we saw was at this very early time point, which is at 8 weeks, we saw that there was a vacuolization of the cardiomyocytes. So we can see here that there were a vacuola within the cardiomyocytes, and most probably this was the reason why these animals, they had increasing water content in the tissue, which also we quantify by this desiccation technique, and this was correlated to the presence of this vacuola. The fact that at this early time point in which we saw there was a T2 prolongation with the vacuola and extracellular volume was completely normal or unchanged compared to baseline, was also somehow indirectly telling us that the edema was intracellular, even though it's very tricky to differentiate between extra and intracellular edema by MRI, as Matthias can tell much better than I do. And later we wanted to see whether this increase in T2 mapping, which happened to be the earliest CMR marker, could have some prognostic implications. And this is why we decided to do another group of animals. Let me go back to this scheme slide. Sorry. This one, and this group 2, in which we were given only 3 doses of doxorubicin intracoronary every 2 weeks, the same as in these animals, but we stopped doxorubicin at the exact time point when the T2 start to get prolonged. And we wanted to see whether eventually this might result in also development of cardiotoxicity, and in that case, this early marker would have been only a marker but without any prognostic significance, or by contrast, if the stopping doxorubicin at the time in which we saw there was a T2 prolongation eventually reduced the incidence of cardiotoxicity. And in fact, this is what we shown. So here you can see in these animals in which doxorubicin was stopped after the third dose, in orange in this graph, you see that the left ventricular ejection fraction was completely normal throughout the entire course of the study. There was a prolongation in T2 after the third dose, as it happened in the first group. But then after that, when we stopped doxorubicin, the T2 prolongation recovered normal values, and also there was no changes in extracellular volume. So we demonstrated in this case that after 3 doses of doxorubicin, at the time at which we see that there was a T2 prolongation, if we change the protocol, in this case we stopped doxorubicin injections, this was enough to prevent the development of cardiotoxicity. So this was our study, and at this case we thought that this might be a very early marker of intracellular vacuolization, so intracellular edema secondary to the binding of doxorubicin to mitochondria, and eventually the elimination of this mitochondria by vacuolization. And at this early stage, if we stop doxorubicin, this vacuola completely disappear, this results in a normalization of T2 relaxation times, and this precluded the evolution to cardiotoxicity. So in summary, this was more or less the study, and I'm very happy to go over the details and discuss anything that you might want to discuss.
Thanks a lot for this excellent presentation of this really outstanding paper. I think there is, I say this rarely, but these are, to my taste, at least in an experimental level, these are landmark data, and I congratulate you for the really very elegant design of the study and the clear story you're telling. Are there any questions from attendees? I know that some of you are also working with cardio, following several hypotheses. This one is certainly interesting, that T2 precedes other or more irreversible damage, and we know that from other disease, but it's particularly important that in cardiotoxicity this may be a little bit later than usual. So are there any questions from anybody? Just either unmute yourself or put the question to the chat, then I could pose that for you. About that, I would have one. So there was an accompanying editorial, which basically with the message, there was a significant critique. The only limits were discussed there were that the injection was an intracoronary injection instead of a systemic approach.
Yeah, so this was one of the main critiques, and I think it's a fair critique. Sorry, I lost the sound. Go ahead, sorry, I lost the sound.
Okay, so I'll repeat it. An accompanying editorial mentioned that the injection was an intracoronary injection and not a systemic, as you would have in clinical scenarios. So do you think that would be a significant limitation to the validity of the data?
Of course, there is a limitation of this model. We were forced to do this because we wanted to have a significant increase in the concentration of doxorubicin in the heart without these myelosuppressive effects. And as long as we are comparing this effect of doxorubicin in the heart, no matter how the doxorubicin was injected, I think this paradigm also will apply to the intravenous administration of doxorubicin. In fact, as I mentioned before, this is still unpublished data, but we have been doing experiments in which we were administering intravenous doxorubicin, and we have not been able to induce cardiotoxicity, and the T2 was completely unchanged. But if these animals, they have some pre-existing damage in the myocardium, something similar to this, the dual kit hypothesis, now we have been able to achieve cardiotoxicity by intravenous injections of doxorubicin, and this was preceded by the T2 prolongation. So I think this is the extreme model, the intracoronary injection, but I think this does not preclude that this paradigm also would apply to humans which receive intravenous injections of doxorubicin.
Okay. So that's especially interesting that you could that you have some preliminary data that intravenous. So that's good. So that was what I would have expected, that the intracoronary injection would not be too different from, because the intravenous also, it's a very short. We know this from first pass perfusion imaging. It's a short way to the heart, just one pass to the lung. So any other questions from any of the attendees? So another one I had actually is also mentioned by the editor. So there are some, I don't know whether they are published or yet, but I saw an abstract at the recent German cardiology meeting using strain imaging for cardiotoxicity, and especially a novel technique called FSENC, and they claim to be very sensitive, even very early. Now, cine imaging would allow you to, with some methods, to actually retrospectively analyze strain imaging. You have done cine imaging, so I was wondering whether this is something you considered, that you use the cine images for a retrospective strain analysis and maybe look at the correlation between functional changes and tissue changes.
This is a great question. So starting by doing some ad hoc sequences, we are also in another batch of animals. We are replicating exactly the same experiment, and we are acquiring SENC, regional deformation, and we will see whether this SENC, when this is affected. I would anticipate that the T2 mapping prolongation is going to be much earlier than any deformation technique. So we are in a previous experiment in which we were giving weekly injections of doxorubicin, which was a preceding experiment to this one. We also quantify feature tracking by the CNA images that we already acquired, and the changes in feature tracking were exactly parallel to those of decline of left ventricular ejection fraction. So in that experiment that we have not published, and hopefully we will publish later on, we observed that the T2 prolongation occurred much earlier than changes in feature tracking, which is not exactly tissue formation, but is the thing that we can get from the CNA images that we acquired.
Yeah, no, that's very interesting. I also would expect that that functional changes should probably at least significantly occur, especially when you have extracellular edema, because that increases stiffness of the heart, and then, of course, the whole diastolic process is impaired. There's one question from Theodore Murphy. Thanks for posting that in the chat, and he's asking, what do you think would be the ideal frequency for CMR timing to detect early change? So you saw it between 4 and 6 weeks, but for clinical scenarios, so would you then do you think we should, if we would apply this clinically, start at, let's say, 3 weeks and then do a weekly scan, or what do you think one could do?
This is also a great question. So in pigs, everything is accelerated, especially because of the model, and also because we were giving doxorubicin intracoronary. So we expect that in humans, this time frame would be much wider. So you would have a wider window to eventually to visualize the changes before any abnormality in contractility. Now, currently, we are doing a human validation of this study, and what we are doing is we are doing a CMR immediately before each of these cycles, and we are including patients with lymphoma who are receiving R-CHOP, and which is every 21 days, so every 3 weeks. So at this moment, we are doing MRI immediately before each of these cycles. So I think that every 3 weeks before cycles, eventually in patients at higher risk of developing cardiotoxicity, would be a very good protocol, but let's see when this happens.
Yeah. Okay. So to me, this also nicely echoes a change in transplants. So we also discussed recently papers on using T2 for the early detection of rejection. So to me, that's a little bit similar. The protocol could be actually the very same, just to do a quick look at function and then a T2 map for identifying early acute changes. There's a question from Reza Nezafat. Asking, can you comment on the regional variation of T2? So were there differences between, let's say, septal and infralateral, for example? Sometimes some of these regions are more severely involved than others, maybe specific to the underlying pathological process. So did you see any variations?
This is a great question. We saw that there were differences, and the changes were more dramatic in the anterior and the septum than in the posterior lateral. But since we were injecting doxorubicin in the left anterior descending coronary artery, eventually the concentration of doxorubicin was much higher in that region. So we cannot speculate whether intravenous would have also resulted in differences between septum and posterior lateral.
Yeah, so it may be that in clinical scenarios we may experience a more homogeneous, but that would be we would have to wait for your experimental data giving that intravenously. So I think about 16 years ago we published a paper from Berlin looking at cardiotoxicity, and we saw that an early inflammatory response was associated with a late loss of ejection fraction as a global functional marker. But you haven't observed any signals at all at early stages. So it was neither as far as this, but there were not even a few animals where there was an early signal after the first dose or so. So you think a single dose would not lead to significant changes according to your observations?
In this model, we didn't see any change after the first injection, but we cannot exclude that eventually by intravenous injection or in humans or differences this might happen. But in this case, all the animals behave very similar one to another, and we didn't see any sign after the first injection. Eventually, this might also relate to eventually to some other comorbidities in humans which were not present in these animals. So this is why eventually.
Okay, so there's a question from Giselle Melendez from Wake Forest, and they're also doing quite a lot of interesting research in animals. And she's asking, do you think a cancer model would change the CMR imaging biomarkers? If I understand the question correctly, that the cancer model, whatever model you use, would define which markers you would have to use to identify this particular damage. Or maybe Giselle, you can also chime in and just unmute yourself and maybe specify the question.
Okay, can you hear me?
Yes.
Oh, wonderful. No, I was talking about the tissue characteristics. Do you think the cancer per se may have an influence on, in the variability of the T1 and T2 and therefore ECV as well?
Well, this is a great question. We're not going to be able to solve with this model because in this pigs we are not able to have any model of cancer to see whether this affects the tissue characterization or the changes in the tissue. But I think that this is really plausible because in some other studies that we have done, clinical studies, so this was not experimental studies, in which if you are scanning patients who undergo any anti-cancer therapy, most of them, they already have some changes, so they have eventually T2 or T1 abnormalities. So eventually this might be secondary to the cancer itself. So this is plausible, but we cannot answer from these experiments.
Yeah. Thank you. And there's also a question from Ezekiel Guzzetti. And he's asking, have you experimented the influence of cardioprotective medications such as dexrazoxane, beta blockers, or ACE inhibitors on T2? Probably that may be one of the next steps, but have you done any of that already?
We have an ongoing study testing these drugs. So sacubitril valsartan we are testing. Also, we are testing carvedilol, which was negative in the previous trial. And we're doing some animal experiments to see whether this administration of these drugs eventually might prevent the development of cardiotoxicity, and also which might eventually have any change or any effect on the early changes that we observe by T2. But so far these are ongoing, so we don't have any data.
That's excellent. Thank you. Okay. Thank you very much. Any other questions? So if that's not the case, I would like to, if you could unshare your screen, I would. So first of all, thank you so much, Boria. That was a fantastic journal club today. I really enjoyed it. I'm happy that we focused on one paper plus the editorial today because the discussion was so interesting that I would have found it hard to move to something else. So here, just for the sake of completion, so this is the editorial. It's also posted in the journal club. So who's a member of the journal club can access that paper that discusses, but largely confirms what Boria already said in terms of the potential, and has basically, we discussed everything that was in that editorial. So as a brief announcement for next week, we will, so in 2 weeks, the next journal club will discuss topics around coronary angiography, and we will discuss specifically these two papers. So one, and Marcus Henningsen will be there to present their paper called Visualization of Coronary Arteries in Pediatric Patients Using Whole Heart Coronary MRA, a comparison of image navigation and standard approach for respiratory motion correction. And then the other one will be from Matthias Stuber's group, from Jerome Yearly. They do a lot of stuff with an approach called free running framework, And this one is called in vitro optimization and a comparison of CT angio versus radial CMR for the quantification of cross-sectional areas and coronary endothelial function. So these are also interesting papers from a very different topic focused on coronary angiography. So with that, I want to again especially thank Boria for joining, and for everybody for attending and for the interesting discussions and contributions. And I want to say goodbye. This time I will actually do something I usually don't do. I will turn around my computer just to show you where I am. I'm here at in Venice, and actually really came from the airport and just made it a minute before it started. And will now go to my hotel, and tomorrow we'll have a workshop, and then we'll have the Euro CMR. I hope to see maybe some of you there. And otherwise, I wish you